Thank you. Good morning, everyone. My name's Richard Watson. I've been invited to talk to you today around some of the changes that have taken place with the development of integrated care systems and particularly integrated care boards. And I hear I'm a guinea pig for this new approach with Teams Live. So hopefully all the technology works effectively this morning. So we're going to be running this session till around 12:15. So I've got a set of slides that I'm going to talk through. And then as we go through, if you can pop any questions that you might have in the chat function, and I'm ably assisted by Megan today, who's going to be reviewing them and then popping them down. So I'll be looking at them at the end of the presentation, if that's okay. We'll go through them once I've finished. So just to start with, a little bit about me. So as I said, I'm Richard Watson. I'm currently the Deputy Chief Executive and the Director of Strategy and Transformation for the Suffolk and North East Essex Integrated Care Board, which is a bit of a mouthful. And I'll explain a little bit about the organisation in a second, but just about me. So I've been working in Suffolk and North East Essex, so in the east of England, for the last 8 years in effectively the old clinical commissioning groups and then through into the ICB from July. Previously to that, I worked in the London system, North Central London, for 10 years in a number of different roles, starting out in local government and then into healthcare. So I've worked across both the old Strategic Health Authority, Acute Trust as their head of transformation, and then more recently into commissioning in CCGs and then into the ICB. And for my sins, I was an elected councillor for 4 years and cabinet member in one of the London authorities. So my current role, just to ground it, so what do I do? So I lead on strategy for the organisation and the wider system, developing particularly our 5-year strategy. Again, I'll touch on that a little bit later. I also lead on strategic planning, including the development of our 5-year plan. Again, I'll touch on that in a bit. And I have the joy of our annual planning cycle, which we're in the middle of now. Many of you will obviously be part of that in your own roles. I'm also fortunate to be Senior Responsible Officer for Cancer and for Mental Health for Suffolk and North East Essex. So I have a lot of focus on those two particular areas across our geography. As part of my executive lead role, as well as those other things, I also cover children and young people, specialist commissioning, which is coming back to ICBs from next year, our intelligence function, which is our business and informatics work that we're doing across the system, population health management, which is our way of trying to understand our local population in a more analytical way and understand what our inequalities are and then put in different interventions to support. Our provider collaboration, which I'll touch on later, and also our dental transformation work. Dental is coming to ICBs from the 1st of April, so we're taking on commissioning responsibility for that from them. I've also got a wider role in Essex where I lead our special educational needs and disabilities commissioning, and then anything that doesn't fit tends to come my way as Deputy Chief Exec within the organisation. So just to ground where we are, Suffolk and North East Essex ICS. So we're the geography there in the purple, and we've got 5 other ICBs that make up the east of England. So you'll see the neighbouring ones, Mid and South Essex, Norfolk and Waveney, etc. We are about 1 million head of population, so we're probably in the middle of the pack in terms of the size of our ICS, comparably to the other 41 across England. And the changes, as you'll know, that came about in 1st of July, abolished the old clinical commissioning groups and created the new NHS integrated care boards that I now work for. So in terms of some of the different parts of the new architecture, you'll be glad I'm not going to talk about all of these, but I just wanted to talk a little bit about some of the organs as we describe within our system that make up our overall integrated care system. And the two at the top are the ones I want to touch on in this presentation on the whole. So the one on the left, the Suffolk and North East Essex Integrated Partnership, and on the right, the Suffolk and North East Essex Integrated Care Board. And across England, we've got a similar arrangement in the other 41 geographic areas. Each have got an ICP and each have got an ICB. In Suffolk and North East Essex, we're really proud that we've also got 3 alliances at our place level. So each of them around 250 to 300,000 population, North East Essex, Ipswich and East and West Suffolk, and they collectively then make up the overall geography for our local patch. Forgot there were so many click-throughs. In terms of then what is the Integrated Care Board that came into being from the 1st of July, This is just kind of some headlines on our responsibilities. So it's not all encompassing, but it just gives you a flavour of what we do and what we are. So the ICBs bring the NHS together locally to deliver a set of shared priorities. And there's a much greater emphasis through the changes on collaboration and sharing responsibility across the old commissioning organisations and our provider and local authority partners and third sector. So collectively being responsible and accountable for the health of that local population. We've taken on effectively the majority of the old duties performed by the clinical commissioning groups that were abolished on the 1st of July. And as I alluded to in my previous slide, we're also increasingly taking on different responsibilities from NHS England, starting with dental, optometry and pharmacy, which have traditionally been commissioned by NHS England, that I think pretty much all of the 42 ICBs are taking that on from the 1st of April in the new financial year. So our main role is to plan, develop, commission and oversee the performance, and that's finance, quality and safety of healthcare services within our local patch. So for me, Suffolk and North East Essex. And just to kind of give a flavour of what that includes: primary care, community services, acute, mental health, learning disabilities, maternity and children and young people. So effectively, pretty much the whole gamut of healthcare services in a local geography. We've got a variety of system programmes of work in all of those above areas, and particularly within our ICB and our wider ICS, we've gone for a number of different joint change or delivery teams. So rather than the ICB having its own commissioning change team and say our acute providers or our mental health providers and indeed local government, over the last few years we've been bringing teams together so that we've got integrated change and delivery teams supporting the development and delivery of our work locally. And our governance reflects the changing nature of the arrangement. So this slide's a little busy, but I think it's just useful to give you a sense of the change that's happened since the old clinical commissioning groups vanished on the 1st of July and the ICBs were formed. So effectively, we have a board like any organisation that oversees the work that we do. So starting in the middle where it says members, we're led by a chief executive, Dr. Ed Garrett, who's my boss, and we have a chief finance officer, a director of nursing and a medical director. So they make up the 4 core board roles within our organisation. We've also, this is the change from the previous CCGs, our other members now are our acute, community, mental health, primary care and upper tier local authority partners. And we, slightly differently to the majority of other ICBs, we also have a voluntary care and social enterprise sector representative. So each of those, I guess, facets of the NHS and our partner local government agencies are actually voting members of our board, which is a big change from the old arrangements, where effectively it was a set of directors, including myself, exec directors, and the GPs following the 2012 Lansley reforms. Importantly, though, on the left, we also have our chair, Professor Will Pope, and 3 non-exec members who effectively were interviewed and brought onto the board, applied and joined, who bring external expertise into the work that we do. I'm a regular participant alongside my other director colleagues, so in the 3rd box along. So although we're not voting members, we attend every meeting, and obviously a lot of the agenda is very much driven by our particular portfolios. And then finally on the right, we have a number of observers, including importantly Healthwatch Essex and Healthwatch Suffolk. So those are the organisations that effectively are increasing the voice of the local population into our discussions, and each of your areas will have your own Healthwatch organisation. That's just a bit of a rogues gallery of the people that I've just talked about. It won't mean a lot to many of you, but just to say these are the individuals that make up our board. I won't touch on this one heavily because I'm sure it's not coming up very well on your screen, but just to say, underpinning that board I just described, like any organisation, we've got a number of different committees and forums that report into the board. So everything from the green box, which is finance, quality, estates, procurement, through to our transformation programmes in the red, which is our ICS wide programmes, including urgent emergency care and cancer. But as I said earlier, what I think slightly marks us out from some of our neighbours is the place-based partnerships. So that 300,000 population I talked about on the earlier slide, West Suffolk, Ipswich and East and North East Essex, we've actually delegated a number of responsibilities from day one down to those 3 local places, starting with primary care, medicines management and community health care. And we've got an ambition to go further as they further develop over the next year to 18 months. So what are those alliances? So effectively, they are almost a mini ICB. They're a set of organisations that came together about 4 or 5 years ago. So that's our main healthcare providers, voluntary care and social enterprise sector, and local government, both upper tier and lower tier. So I know some of you will only have effectively one unitary authority, particularly London, but many local counties have a 2-tier structure where you've got effectively local borough councils and then a county council. So we have membership within each of our forums or our boards, our alliance committees in each of those 3 geographies, and each one has a leadership team. So we've got a alliance director for each that reports into our chief exec, but importantly also reports into local government through the chief execs of those local councils in that patch and the county council. And there is also a jointly appointed operations director who brings together adult social care and community health care in that local patch, which has been a big game changer for us over the years with making decision making across health and social care for that local population. Importantly, though, underpinning each of those 3 areas, so West Suffolk, Ipswich and East and North East, they also further break down into something called localities. So that's around 50,000 head of population. So we've got altogether 6 in West Suffolk, 8 in Ipswich and East and 6 in North East. And each of those, again, have their own joint operational manager who works across health and social care, which has actually, again, started to break down some of those barriers between those different professionals, particularly in how they work with individuals, the local population. Each of those has their own delivery plan that's very much reflecting the specific needs of that local community, because I'm sure, like many of you, we have stark inequalities across our geography, with some of the most socially economically deprived areas and some of the wealthiest areas in the country being situated in our geography. So what we actually need to do and work with our local population is very different within each of those localities. Really importantly, sitting alongside then that integrated care board, so the organisation that I work for is the Integrated Care Partnership, and again all of the areas of England will have an ICP. So within the legislation that came into being on the 1st of July, they formed also an integrated care partnership. So it's not an organisation and it's not a statutory committee, it's a partnership, as it says on the tin, of a wide variety of different local partners who come together, and you'll see in the circles on that diagram the headline of the different sectors, the different organisations that are coming together. This just gives you a flavour. You won't possibly be able to see, but we'll send the slides after this session, actually then the specific organisations. But it's deliberately a wide set of partners, about 60 to 70 individuals, so we get the most as we can representation across our local patch as we start to develop our strategy and work on some of the wider determinants of healthcare, both education, economic growth and regeneration, and jobs, etc. That's our 3 chairs, Councillor Reid, Councillor Spence and Professor Pope, so they alternate the chairing of the ICP. Importantly, Councillors Reid and Spence are also the chairs of the Essex and Suffolk Health and Wellbeing Boards, so that's another existing predominantly local government led forum, and we were really keen to have the interface between these two through the chair of those 2 individuals, and Professor Pope, as I mentioned earlier, is my organisation's chair. Just going to finish then on 2 of the biggest things we're working on since our formation on the 1st of July is the main duty of the ICP, so the partnership I just talked about, is to develop a 5-year strategy. So each of the 42 areas of England have been busily working away on this between July and December just gone, as the national expectation was each of the 42 ICPs published their 5-year strategy by the end of December. Alongside that, and complementing it, each of the 42 ICBs in England have been asked to develop a 5-year forward plan. It's effectively the delivery plan for the local population in terms of healthcare over the next 5 years. And the guidance came out just before Christmas, and it's asked us to have those in place and published by the end of June. So you'll find that if not already, I'm sure you'll hear that each of your areas that you work in are currently working on that with the aim of getting that published. So for us, also in addition to that, each of our 3 local places, Ipswich and East West Suffolk, North East Essex, are also developing their own local delivery plan. So they all interlink with each other, starting at strategy, overall plan for our geography, and then a localised plan build, kind of taking its lead off that in each of those 3 local places. For us, we've developed what's called a live well domain approach to all of these documents, starting with what you'll see on the left at the bottom, start well, all the way through to die well. So we've committed to 6 high-level outcomes, each related to those 6 domains you'll see there. And underpinning that, you'll see it's not completely exhaustive list, but the main areas that we are covering in our joint forward plan. Many of them I'm sure will resonate with you, but effectively it's all the various facets of the commissioning responsibilities that we have. So we're busily working on that, and we're hoping within SNEE to have that in place by June at the very latest. If you want to find out more information about us, there's 2 links there. The first is to our main ICS website, and the second is our engagement platform, which is called Let's Talk SNEE, which is the platform on which we're currently out to engage with our local population and partners on that 5-year plan that I've just talked about. So that's a bit of a canter through some of the changes that have come about since June, and I'm happy to take any questions. So Megan, have we had any come through yet? Otherwise, an opportunity now to get them typed in the chat.
We haven't had any questions come through just yet, but there was a request around, are we able to share the slides that have been provided? And I've said, yeah, that's absolutely fine. But
Brilliant.
no questions at this time.
I'm not going to sing, so I'm hoping that we will get some questions coming in. Don't feel they need to be exactly on the specific one of the slides, although I'll try my best to answer anything that you're interested in.
I think we've just got one come through. I've popped it in the published section.
Great. So as a trust, we're keen to be able to share patient level data with another organisation with our ICS. Do you have any data sharing agreement set up? Absolutely, yes. So as part of that opening slide, when I talked a little bit about my specific portfolio, I'm leading on the development of our intelligence function. So effectively, by the end of March, each of the ICBs needs to have in place a population linked data set for effectively to enable us to better understand, plan and target our work for the local population. So within SNEE, we've now commissioned one external organisation to provide that data set, and we are going through, and it's quite a laborious exercise of getting data sharing agreements from each of our 60 odd primary care to our GP practices. We've already got, through existing work we'd already been doing in SNEE, our major acutes, our county councils and mental health trusts. But we're just going through that process now. More than happy, I can't see who the name is, but if you want to drop Megan an email separately, I'm happy to follow up with you if it's useful to link you with our particular lead on that, if there's any help we can give with the approach we've taken.
Fab, thanks Richard. I'll send that over if they do get in touch with regards to that one. It doesn't look like we've got any more questions coming through at this time, so happy to close there if you are, Richard.
Okay, I'll just give it another minute or two. I know that was probably a bit of a brain dump of what's happening across the world of commissioning ICBs. Anything around how you're working with your own local system? Any particular challenges that you're facing?
I think we've got another one coming around PBR element.
So this one is, how will the PBR element for 23-24 day cases and elective care impact on provider innovation and collaborative working? Will this encourage cost-cutting strategies that may impact patient care? So just for everyone else's benefit, the planning guidance that's now being issued just before Christmas has included within it some changes to the way in which we will be commissioning elective care within each of our local patches and with our providers. So particularly within SNEE, for many years we moved away from payment by results to what we call guaranteed income contracts. So effectively we agreed at the outset of the year with each of our major providers the amount of funding that collectively we felt we could afford and was reasonable, and then we worked together to try and to deliver within that, including actually jointly owning the challenge rather than seeing it as a commissioner going, it's over to you, provider, crack on with it. And that's where a lot of our joint change teams came in. So effectively, we don't have a separate commissioning. We haven't for years had a separate commissioning team and then provider change teams. It's been one, and we've worked together on those challenges. I think it will be a challenge for us in terms of effectively moving to payment by results for those elements. And I would hope, and particularly within our system at least, it wouldn't move us away from the work that we are doing around this being a joint challenge around our elective recovery. And actually, I think innovation is even more important because of the challenge we've got to meet over 100% of 2019 activity. We're going to have to think differently around how we do it, and indeed we are, because the workforce is not there to carry on doing traditional mechanisms for how we've approached this over the previous years. But I think it really depends on the second point, on the collaborative, around how your system's already working around that kind of joint work I've described. So in SNEE, as I say, for years we've been working in that collaborative fashion around majority of our change programs and the approach we're taking to financial sustainability. Any other questions? No problem.
Yeah, there's quite a few come through now. So
oh, I need to scroll down. There we go.
Yeah.
Please, in summary, are you able to sum up main challenges and actions you are taking? Oh, so I think we're not unique at all in this. The main challenges, I guess, for us is threefold. One is workforce. So I think, like most areas, we are struggling with recruitment and retention, and I think actually for us retention is the biggest challenge. Retaining people within the NHS and with wider services to provide is an ongoing challenge that we've got. The second, given the audience today, would be finance. So we are not we've got a challenge position. We're not the most challenged, but I think going into this next year, I think it will be one of the most challenging positions we've had for about 3-4 years. So there's a lot of work for us to do, and actually, as I said in previous question, to understand how we can try and meet those financial challenges collectively, rather than kind of go retrench back into our own organisations and see it as our own separate problem. And the third one for me would be morale. So I think it's fair to say that morale is challenged, but I think there is an opportunity to try and continue to approach that in a different way, with harnessing the skill set of all of our individuals in our system to try and find solutions to some of the wicked challenges that we've got. How do you think Section 75 will be used going forward, in particular the desire in some localities to create a tripartite arrangement with providers, council, ICB? I'm probably stretching my knowledge a little bit on this one, but I'll just give you my own perspective on this. I think Section 75 and the Better Care Fund are helpful in terms of trying to look at different approaches to how we pool funding. However, I don't think, as a non-accountant, a non-finance person, I don't think they're the be-all and end-all. I think for me, it's more about the underpinning relationship between the different partners, particularly across local government and healthcare, because I think you can also get more pragmatism if you've got those good relationships on how we look at aligning budgets rather than necessarily pooling. So if I give you an example, within those, as I described, within those 3 local alliances, so Ipswich and East and West Suffolk, we have that joint director for adult social care and community health services. And then under them, as I described, within each of the localities, we've got a joint health and social care manager. Now, at the moment, they're effectively responsible for their local adult social care budget and their local community health budget. There is a pragmatic approach to how that money is used. So rather than try and tie ourselves in knots in a kind of a long Section 75 agreement or something else, we've set some parameters around what that local manager and then that director has got responsibility and the ability to make decisions around the use of the pots that they've got responsibility for. So I think that's just another mechanism through which you can get some of the advantages that come sometimes with kind of bringing funding pots together without necessarily going through a formal Section 75 agreement. What's the biggest change you've felt in the move to ICSs? For us, I don't think I'd describe it as a big bang from the 1st of July. We've been working in this way for about 5 or 6 years. So if I remember when I came here 8 years ago, coming from, again, the North Central London system, we were still working that kind of traditional approach of a commissioner provider and local government. And I think over the years, we've moved away from that. And we were a vanguard wave 2 ICS system. So we weren't in the first, like Frimley, etc., but we were in the second wave. I think there was 4 that joined the programme. So for us, this has been a natural progression. So we were really collectively happy, pleased with the changes overall that were brought about through the legislation, because it played in to the approach that we were already taking. I think the welcome change for us, though, as I described, is the ICB board makeup. So the fact that we met on Tuesday, I've now got the chief executive from our acute community, our mental health trust, local authority, GPs, all sat around the table who are jointly accountable for the development delivery of healthcare in our local patch, I think has continued to change the dial away from it being that's your responsibility, that's yours, to this is ours, and how we're going to work collectively together. And I think once we've landed that joint forward plan, so that 5-year delivery plan I described, again, which all the 42 areas are working on, I think that will give us a real focus for those organisations. Now, the one thing we are doing is, you'll, I'm sure, recognise this, is there's 1,000,001 different priorities within healthcare. So what we're trying to do is not say that everything's not important around those 6 live well domains I described, start well through to die well, but we're trying to aim to get 10 big commitments or 10 big ideas, and the board effectively will collectively own those 10 big commitments, and that will help frame the board meetings and some of our focus work. We'll see how it goes, because obviously it's early days, but we're hoping to have nailed what those 10 are by the end of March, when we've got our next board meeting. How is the contracted commissioning changing for your ICB? How are you planning to reduce the transactional element of contracting? Absolutely. So I won't repeat everything I've just said, but for us, we've been working in a different way anyway for a number of years. So as I said, again, we've not had a traditional approach with having a director of commissioning. So I'm the director of strategy and change, and have been in the old preceding organisations, and we've got a director of performance improvement. So effectively, you look at the old commissioning cycle, you'd have traditionally a director of commissioning. We don't have that. We have the 2 posts I've described, and then our 2 teams work really closely together, jointly with our providers, and increasingly, as I described, with joint teams on the whole commissioning change delivery process. As an example of that, we are looking within our mental health side to look at having effectively joint contract posts. So contracts are important, they're never going to go away, but equally it's about the relationships and the approach and the ways of working that enable that contract to flourish and to work. I personally think it's a failure if you have to go back to the contract. If you're getting to that stage, you know, something has gone wrong in the relationship or the approach to how you're tackling some of those challenges. So I think longer contracts is the other element. So we're trying to move away from the kind of annualized or every 2-year contracts. So we've got hundreds of contracts. I'm sure many of your commissioning organisations would have, and you end up tying yourselves in knots with going through a perpetual cycle of review. So for us, we're trying to move away from more collaborative contractual agreements and longer contracts to trying to reduce some of those elements. Final thing I'll say on this is also we're trying to move away from ourselves having a set of kind of contractual meetings, and then internally within our providers you have your own finance or contracts or quality meetings. So actually our leads are actually going to those meetings, so they're getting their assurance from attending and being part of those provider or partner meetings, which I think also is cutting down some of the duplication of effort that we've got. What difference will the public see within the establishment of ICS's ICBs? What improvement from the regional health authorities to the SHAs of other? Yes, so I personally don't think the public care. If I speak to my husband, he wouldn't have a clue around what an ICS and an ICB is, and I wouldn't expect him or indeed our population necessarily to care, dare I say, about the governance and the machinations of the changes. I think from my perspective, what the population want to see is continuing to see an integrated approach across health and social care in its broadest way, and we've still got a long way to go on that. And secondly, that we constantly focus on how we're going to improve those life chances and those outcomes for our population. And again, I think, you know, if you look at the Marmot review, if you look at a number of others, those national reviews, I'm pointing to the King's Fund and other parties, we've still got a significant way to go to prove that. How have you got examples of how you've been working together across the ICS tackle? Yes, so alongside those 6 live well domains I described earlier, so start well to die well, health inequalities runs through the whole of our work. It's like a golden thread running through what we're doing. So within our 5-year delivery plan, there's a significant bespoke section actually setting out what our commitments are to the local population around that. So some of you will know that nationally NHS England launched, I think it was either last year, I think it was probably the year before actually, the Core 20+5. And more recently, in the last month, they've now widened that to a Core 20+5 for children. So what does that mean? So each of the 42 ICSs effectively have been asked to focus on the core 20% of your local population that is deprived, socioeconomically deprived, to choose a number of specific groups or areas that are particularly have an inequality. And then finally, there is 5 specific areas, and I'm not going to try and name them all from memory because I will fail, but I'm happy to share them offline. But to give you a flavour, a couple are maternity, serious mental illness, diabetes, respiratory. So for each of those, there's a particular focus on actions that each of the 42 areas in England need to take to try and tackle some of those endemic and systemic health inequalities. So for us, to give you a couple of examples, say from cancer, which is one of the programmes I'm at SRO for, rather than taking a one-size-fits-all approach to how we're investing our service development funding, SDF funding, to try and transform and change and improve cancer care, we're actually targeting that funding on a needs basis. So as an example, targeted lung health checks. We know that within Jaywick and Clacton, which is one of the most socially deprived populations in Europe, we have significantly higher levels of lung cancer in that local population. So it seems obvious to me and to us that we need to target more of our funding towards that population group on that specific example. Now, that's something that we would like to do more broadly. I've got other examples across the whole gamut of what we do across the system. And one of the things that we're currently debating within our financial community is, do we give a commitment to a specific percentage of our budgets overall to tackle health inequalities? Because even if we gave our budget is £2 billion for the healthcare within Suffolk and North East Essex, even if we gave 0.2%, that would make a massive difference to try and tackle some of those challenges. Next one. How many contract subcontractors do you have? Well, as I mentioned earlier, there are hundreds. So I'm fortunate not to be the director of performance improvements who's got the contract function within it, but clearly work really closely with Paul, who's our lead on that area. As an estimate, I would put it around 200. Now, that sounds scarier than it is. A lot of that is some of the individual contracts with our voluntary care and social enterprise sector, including grants, and some of those would be individual placements. So for instance, on learning disabilities or our continuing healthcare team. So a lot of them are those residential nursing home placements. They're not all organisations in that sense. Do you think that understanding the cost base and the impact of transformation of that cost base is more important than changing the payment system? I'm going to take the politician's answer and say I think both are important. I don't think it's one necessarily over the other. I think one of the things that we are doing at the moment within Suffolk and North East Essex is doing a 10-year demand and capacity plan, which was rather, I think I was being slightly heroic when we agreed to do this because it's proven significantly more challenging than we expected. So effectively, we are working across acute, community, social care adults, and primary care to effectively build up an activity and then a cost base around a do nothing option over the next 10 years. And then what are the interventions that we could make to try and turn the curve on some of that? Personally, I think it's more around activity and cost avoidance or transfer rather than absolute reduction, given the year-on-year increase which we've seen in our activity base across all facets of health and social care. But I think also the payment system, so again, going back to something, the big change we made preceding the changes to PBR was move away from a kind of a payment by results mechanism for most of our contracts to actually using a different approach, as we called it, guaranteed income contracts, to try and basically jointly own the demand and the capacity and the financial challenges that we've got. Just have a drink. Sorry, my mouth is dry. Will there be a formal requirement to report a place level within an ICB, or would it only be at the higher ICB level? I think each of the 42 is probably taking a slightly different approach. So I can talk on behalf of ourselves. So we have, obviously, as I described, our ICB board that meets on a bi-monthly basis. So we have a formal public board meeting 1 month, and then we have a development session the second. But each month we have effectively a performance pack. So that performance pack effectively reports on all of the different duties and responsibilities that we've got, going back to one of my first slides around finance, quality, performance, etc., etc. But we also break it down by the 3 places where we can. So particularly for those duties I described that we've delegated to place, primary care, community health care and medicines management, we actually can cut that by that local area. So within each of our 3 places, there is an alliance committee, and each of those committees also have their performance pack, including their financial performance pack for those delegated areas. So each of them are accountable for that area, but it all comes together through the ICB board, bringing all of the parts together. In terms of sequin monitoring, etc., no, in the sense that acute contracts are still driven centrally, so they are done once across rather than being delegated in each of those 3 local patches. For community services, though, sequin related, I don't think there are many mandated this year from memory reading the guidance. That would be looked at locally. Okay, I think I've run out of questions. Are there any others that people wanted to ask? Last chance.
They are all of the ones at the moment, I think.
No, okay, brilliant. Well, thank you very much. I hope that was helpful. Megan will send out the slides after the meeting, and Megan, feel free to include my email address. I'm more than happy to follow up with any of you individually if there's any other particular questions you've got, or indeed any help you need with any particular aspects of your local work. But huge thank you. Great to see 190. I think we're nearly up at 200. So Megan, I hope that's been a good first one of these.
Yeah, that was great. Thank you so much, Richard, and so many great questions. So gone really well. Thank you.
Thank you all.